Morning, everyone.
Morning. Morning, and thank you all for coming and spending some of your weekend with us. It's really great to see so many faces. So a few points to just share with you. This is an informal Q&A, so we are going to invite you in a minute to shout out the topics that you'd like. If you'd like to put your hand up. The other thing just to point out is that we are filming this, so if anybody isn't happy, we're not going to film your faces, but if you don't want us to film your voices, then please let us know or come and give us your question at the end of the session. We're planning to put this on our National Migraine Centre YouTube channel, because I've had so many people say to me, are you going to be live streaming it? Because since COVID, everybody live streams everything. But logistically, it was a little bit more tricky to do that, so we thought, well, we'll try and record it and see if we can share this information more widely with people. There are some leaflets here, and at the end, you're welcome to take any of the leaflets. We have some QR code posters, just if you want to quickly scan the QR codes to link to any of the things which we discuss, and that would be the National Migraine Centre, the Ouch, which is a charity for cluster headache, and the Heads Up podcast, and my book, but I also have some books for sale over there. And David has a poster which he'll tell you a little bit more about on the side over there. So we're just going to introduce ourselves. Over to you, David.
Thank you, Katy. I'm David Kernick. I'm a GP in Devon, in Exeter, where I've run the Exeter Headache Clinic now for the NHS for about the last 25 years, and I've been involved very much over the last 25 years or so, trying to raise the profile of headache management in primary care, but also just trying to get people with migraine to come forward. And one of the interesting things of just chatting with Katy earlier is that people with migraine suffer a lot unnecessarily. And I just bumped into someone in a shop coming up here this morning. She had a migraine, and she had started chatting to her. She had quite significant migraine, but she never actually sought help for it. She was taking some painkiller that she'd got off the internet, which is not helping at all. So Katy and I have been really quite passionate about addressing unnecessary suffering. And for some reason, people suffer with migraine and they don't even come forward, let alone get adequately managed. So it's a big challenge to us, and that's what we've been fairly passionate about over the last number of years.
So yeah, I agree. I mean, I now can't go anywhere without having a conversation about migraine and people saying, oh, I didn't think I had migraine. I thought it was just a normal headache that everybody gets. And I say to them, well, you wouldn't say to me, I just get the normal rashes that everybody gets, because people would go, why have I got a rash? So a headache is needing a diagnosis. So I work for the National Migraine Centre, and I do a podcast, and I've written a book as part of my work in trying to educate people, because when I first started having migraine attacks, I was in my early 40s. I'd never had any migraine attacks before that, and it took me a while, even as a working GP, to think, oh, am I getting these headaches? And eventually the penny dropped, and I went to the National Migraine Centre as a patient, and a few years later, when I changed my career pathway, I ended up working for the charity, and the rest is history. Here we are. So that's why I think we hear in clinic every day really sad tales of people who've spent a lot of time trying to struggle on with horrible, impactful attacks, and finally go, oh, I need to go and find some help. And luckily, sometimes they find us, so that's good. So, do you want to talk about the 3 points?
I want to make three statements, actually. So, the first thing I want to say is it's not your fault that you have migraine. A lot of people are sort of self-critical and self-blame, but migraine is a genetic problem. You have a disposition towards migraine. And what happens is you have a hypersensitive brain. And historically, when all these reflexes were laid down hundreds of thousands of years ago, that was an advantage to your survival. But now, everything is happening all over the place compared with a few 100,000 years ago during our evolution. Lights everywhere, sound everywhere, stress everywhere. So a hypersensitive brain doesn't act as well as it used to do when we first evolved. So it's not your fault that you have migraine, you have a genetic predisposition. The second point I want to make is that you're not alone. About 12% of the population, more females than males, have about 8% of males and slightly more females have migraine. So significant numbers of the population have migraine. And for females, during the ages of between about 30 and 45, over 25% of the population will have migraines. A lot of people, actually. So you're certainly not alone. The disability that migraine causes is well recognised. The World Health Organization puts migraine as number 6 in the world in terms of disability, in terms of diseases. In young people under 25, it's number 3. So big impact at work, at home, in the family life. So a lot of unnecessarily suffering going on out there. And the third point I want to make, just to start with, is unfortunately at the moment there is no cure for migraine. There's a lot of research going on, but currently we're all about control. So Katy and I, what we want to do today is share with you some information so you can understand things a little bit better and shift the locus of control. So rather than your migraine is in control of you, you are in control of your migraine. And one of the sort of metaphors I quite like that came out from some work we did with people with migraine is the beast on your shoulders. So these people who had migraine saw it as a beast that's sitting there always ready to strike, never knowing when it was going to bite them. So the beast will never go away, unfortunately, at the moment, but certainly what we can do is get it so the beast stays in the kennel, and when it does come out, you can put a collar on it and keeps it under control. So I think that's quite a nice way of thinking about what we're after. You know, unfortunately, or some people, the medications that we use these days can abort migraine altogether, but in most people, we're looking for better control of your problem. I think that's right. Would you agree with that, Katy?
Yeah, definitely.
So the next thing, having made those 3 opening statements, I guess the next thing we need to think about is, have I got migraine?
Yeah.
Have I got migraine?
So, have you got migraine?
Well, fortunately I don't have migraine, but Katy will now just map out what we might have.
So we ask a lot of questions. We listen to the story of how people are describing their headaches, and we largely divide headaches into primary and secondary. So secondary headaches are those where you can point to something and say, oh, that's the cause of that headache. So it might be an infection, it might be a bump in the head, it might be somebody's unfortunately had cancer that's spread. But the largest majority of headaches fall under the primary headache, which means that they are the condition themselves and not caused by something else. And there are 3 main types of primary headache that we recognise. Tension headache, which is often thought to be the commonest headache, but I think in our clinics we don't see that so much. We see vastly, the majority of our patients coming in are suffering from migraine, and GPs who are seeing people with headache, almost invariably it is migraine. Tension headache is a dull, band-like pain around the head. It doesn't really have the same associated features that migraine does. So it doesn't have the sensitivity to light and movement that migraine does, and it often is not associated with nausea and vomiting. Migraine is by far and away the most impactful of those primary headaches, and it comes with a whole plethora of other symptoms. So the ones I've just mentioned, sensitivity to light, sound, touch, or movement. It comes with nausea and vomiting, and we'll talk about that a little bit more because it's really important to get to grips with that if you are trying to treat migraine attacks effectively. But it also comes with brain fog, with thinking issues. People say it's hard work to think. I've certainly had that. Sometimes it comes with aura. We divide migraine into migraine without aura and migraine with aura. And only about 25 to 30% of people get aura. So that's usually a visual disturbance. They often draw it in the air and say, oh, it's like a zigzag and it goes out. So that's very typical of visual aura. But some people get sensory aura in that they have funny smells. So they might say, oh, I just smell cigarette smoke and nobody's smoking around me. Or they may have, much rarer, they can have auditory hallucinations and think that they're hearing things that aren't there. But the vast majority of people with aura, it's visual. And then the third group, which I will mention because we can talk a little bit more about it, are what's called the trigeminal autonomic cephalalgias. So sometimes we call those TACs because it's just a lot easier to say. So the TACs include a number of much rarer headaches, one of which is cluster headache. I've put some leaflets down about cluster headache. I think it's really important to recognise the difference between cluster headache and migraine, and we'll come back to that if people would like to know more about how you tell the difference. So that's broadly what we're talking about, primary and secondary headaches, but we're going to concentrate mostly on migraine today and really urging the world to recognise that migraine is not just a headache. There's so much more to it. I talk about migraine attacks rather than migraines, because if you say, oh, I get a headache and I get migraines, people think, oh, that's just a bad headache. But actually, it's a spectrum. Some people get migraine attacks rarely. Some people get them quite mildly. And so I think we have to recognise the real vast complexity of the condition and recognise that everybody who has migraine needs to understand it.
Yeah. Okay, I just want to pick up on 1 or 2 points, if I may. Cluster and migraine. A lot of people call themselves cluster migraine. People with cluster migraine, a lot of GPs get confused because that sometimes migraine does come in little clusters. Now, these two things are really very separate. Very, very rarely you might get two, you might alternate, but usually they're very separate. So you've either got migraine or you've got cluster headache. You have not got cluster migraine. You'll have frequent migraine, but not cluster migraine. So that's just want to pick up on that point. And it may be worth just at this point saying, well, where does migraine come from? So we have this migraine generator, which you can see on special scans at the base of the brain, which fires up when migraine gets triggered off. And this sets off this whole process that Katie's alluded to, and perhaps we just might be worth just unpacking a little bit more about the migraine attack before we go any further. So you have a warning, which is the prodrome. You might all recognise something's beginning to happen. This can go on for a few days before. Then the aura, as Katie has said, and you can get the aura without a headache, in fact. Aura typically 30 to 60 minutes before the headache phase, but it can be longer. Nothing is hard and black and white in medicine. And sometimes people get quite severe aura without the headache. I had one person who had what's called an Alice in Wonderland aura. You get vast distortions of the world, all sorts of funny things happening, visual distortions, without headache. And she was almost sectioned under the Mental Health Act because people thought she was had a psychotic illness, whereas in fact it was migraine. So all sorts of funny things can happen. Then you get the headache phase, forward 72 hours typically. Then often a post-syndrome, a post-drome, where some people feel elated, most people feel washed out. So that's really the sort of package. And there is this migraine generator in the base of the brain. Now it's important just to have a little think about what's going on in this area of the brain, because right next door to the centre is the gastric centre of the brain, where the stomach reflexes are organised. So when this migraine generator fires up, this also fires up the gastric centre, so virtually everyone will feel nauseated, some people will vomit. But the important implication here is, apart from the fact it's not very nice to vomit or feel nauseated, anything you take by mouth for your migraine is not going to get absorbed very well because it will all get held up in the stomach. So you always need to take some sort of agent or anti-sickness agent, or we call it pro-kinetic agent, pro-helping kinesis movement, to help the stomach move on these medications through into the absorption small bowel. So that's the stomach. The other really interesting thing is that virtually all of you will probably spend a fortune on going to see chiropractors, osteopaths for problems in your neck and shoulders, yeah? Do you recognise that? That's because right next door to your migraine centre is where the nerves of the neck and shoulders go in, and they interdigitate with the migraine centre, in fact, it's a migraine generator. So I think what happens is sometimes this migraine generator is firing up. It doesn't fire off a migraine, but it sends signals off into your shoulders and neck, and you're feeling neck and shoulder pain. So in my book, I would say that this is all probably low-grade migraine, so it's not going to be terribly helpful going to see osteopath or chiropractor. So I think those are two important anatomical implications for migraine, gastric centre and neck centre.
I think the neck can trigger off a migraine attack as well if you constantly, like as many of us are these days, looking at your phone and you're putting a lot of strain on your neck and shoulders, and often people with whiplash or injuries find that they get more trouble from migraine attacks later on, and because there's a bit of a bi-directional relationship there. But we've talked a lot now, and this is actually a chance for you to ask us your questions. So would anybody like to start us off? What I'm going to do is write down the topics, and then we will stick them up on the board and make sure that we cover all of them by the end of the session. So anybody with a hand up? Yeah.
I'm sure there's a lot of people here. Could I just find out a bit more about hormonal migraine, and also when you've gone through the menopause, what you can do then, maybe about migraine?
Yeah, that's a big one I love talking about.
Yes, I'm so pleased you asked that. It's a special
We've had to turn the board around because somebody's written all the other side of it, so hopefully you can still see the posters. Anybody else with a question? Yes?
Can I just ask about what you just said about that you trigger the migraine next to the gastric, and if that can work the other way?
Well, that's a really interesting question. I'll just pick up that now quickly now, because it's a niche question. That's a really fascinating question. Because quite often the attack of migraine can be aborted by doing certain things, like pressing on the back of your neck, or we inject these big nerves going into the neck. And we had someone, and it's a well-recognised phenomenon that we sometimes see, their migraine was aborted when they vomited. So what we're thinking of is the vomiting, so there's a huge electrical activity to the gastric centre, which then reboots the migraine centre back to normal again. So it's a really interesting question, and the probably answer is yes, possibly, potentially. I don't know if anyone else recognises that. They vomit, and the migraine gets better. Yes? So we haven't ever thought of inducing vomiting as a treatment for migraine.
What we try and do is get a better rescue plan so you don't have to vomit.
But there is a thing called ipecacuanha that we used to give to kids when they came in having taken too much stuff in casualty, and to make them vomit up the... And ipecacuanha is a treatment for migraine. How about it?
It was more sort of, can gastric sort of irritation then provoke a migraine?
It could do, yeah. And migraine is also very much associated with gastric problems. Virtually, there's a higher incidence of all gastric problems, particularly irritable bowel syndrome and all other sort of bowel problems with migraine, but it could be the other way around, certainly.
So I'm going to put triggers up.
Triggers is an interesting one, yeah, it's a big area. Yeah.
Triggers. And I think we'll also, as David's mentioned it, we'll talk about other link conditions.
Yes.
Comorbidities.
We call these comorbidities in that they occur more frequently with migraine, conditions that occur more frequently with migraine than in people without migraine. These are called comorbidities, of which there are many, and that's an interesting area.
Yes.
Would you be able to speak a little bit about mast cell activation syndrome in relation to migraine?
Oh, that's a good question.
I will happily speak about that.
These aren't prime questions, by the way. We're all excited about these questions, but they're not prime questions.
What we really need is for everybody to come to all 4 of the talks, because we're having slightly different questions.
Yeah.
But what I would say is, if we don't cover your particular topic, or you think of other things afterwards, do head to our Heads Up podcast, because we have a number of episodes on all sorts of different things, including mast cell activation syndrome. I'll spell out a bit more when we come to that, what that actually is and why we're particularly interested in it.
They could always come tomorrow, Katie. We do
Well,
tomorrow.
we are
I'm sure we can negotiate reduction for 2 years.
We do have a lady who has already come twice. Yes.
I'm interested in supplements and things that we can do.
So let's talk about that under the
that comes under the treatment. That comes under treatment, doesn't it? So let's look at treatment in 2 ways. We look at acute treatment, which we mean treatment of the attack when you get it, and preventative treatment, which means taking something every day to prevent the attacks from coming. So we can look at acute treatment, and we can look at preventative treatment. And there's all sorts of things other than supplements. We can, electrics, acupuncture. So we'll cover those under one big topic, Katie. Yeah.
Yeah. There is just so much to tell you. I mean, we booked an hour and a half, but really we could do with a couple of days. So book in.
So buy the book. So yeah, another question in the front row here.
Maintaining a quality of life when you have 5-6 a week.
Okay. Yeah.
Well, I think that all comes under treatment, doesn't it? Really.
And work as well within that.
Yeah.
And work. Yeah. Let's talk
Occupational
about
issues is a big important
work,
one.
Yeah.
Migraine Trust are really good at advising people about issues at work, but we can pick that up. Anyone else got any questions?
Mine was just related to the lifestyle and supplements for somebody that's been on medication for many years. How can you sort of break that cycle?
Yeah.
Does it self-perpetuate? If you keep taking the tablets, are you ever going to free yourself?
No one likes taking tablets. I'm going to talk a little bit about I'm getting more into holistic approaches, so I'll pick that up as well. But what I'm saying is, here's the answer, this is going to be fantastic. Going back to my original statement, we're looking at better management, not here's the magic answer. At the moment, we don't have a magic answer. We have lots of good ideas. Some would work well for some people, some not quite so well for other people. But it's certainly going to be better than what most people are doing at the moment.
Could you say a little bit about chronic migraine and use of triptans as a control?
So we'll talk about chronic migraine, but also medication overuse headache or medication we're kind of
overuse,
beginning to try and not say the word overuse, although it's generally called medication overuse headache. I think both David and I feel that that's a bit kind of judgmental. And we ought to probably be calling it medication adaptation headache or medication survival headache, because the reason people are taking medications is to survive and get through life. And overusing implies that you're a bit...
Bit of an addict,
you're a bit of an addict, or you're tossing them back willy-nilly, and of course nobody really wants to be taking medications, I'm sure you'll agree. So, medication...
You got a question about that?
Just a wee bit more, sorry I was late to join the
no problem.
just about the kind of aura, a wee bit more about the auras, the kind of ocular disturbances with migraine.
Any particular questions about aura? Because we did cover a little bit. Were you here when we covered aura at the beginning?
No, sorry.
Oh, okay. All right.
Yeah, I guess it's just somebody that's just been having them more frequently of late. It's something quite new to me, so it was just a bit about what's happening when that happens.
Yeah. I mean, it's just worth picking up on the fact that migraine does change. It's not always the same pattern. Aura usually precedes the headache. It's a neurological phenomena. All sorts of things can happen. It's caused by a wave of electricity or depolarization that goes across the brain. You can measure it at 3 millimeters a minute, depending on which bit of the brain it's going across. That's what the sort of aura you get. So the most common aura is a visual aura, which happens. This is the visual bit of your brain at the back. So there's a wave of electricity over the back of the brain, but it can be anything. The next most common aura is pins and needles. And auras are always on the move, because this wave of electricity is moving. So the pins and needles will be coming up your arm, the jig-jag lights will be expanding, the central blindness will be expanding. So about 30% of people will get an aura of some sort. And in some cases it's quite severe. What we call a hemiplegic aura is when people get total paralysis. Difficulty with speech. You can get virtually any neurological phenomena. So I think that's all we need to say about aura. But if there are any other questions, we can always pick them up at the end. So we're going to be around at the end for a bit anyway. Is that okay?
Yeah, perfect.
Yeah.
Sorry, can I just ask just to what you were saying about they can change over time?
Yes.
Kind of going back to the genetic thing as well, from childhood, and my mum still suffers them at age 90 as well.
Yes.
So it's just a kind of journey, and the changes are possible.
Well, I think what's really interesting is I call it the long and winding road.
Yeah.
Because we don't really, the evidence-based literature, the scientific literature, never captures a lifetime of people. They never say we never follow people from when they first get headache, which is usually most commonly in teens, early teens. What happens through life and all sorts of things. You go away to college, or you start a new job, and then you get pregnant, or then you start conception, and you have menopause. So all sorts of stuff is going on through life. And all these things impact upon your migraine. So migraine is never exactly the same, it's always on the move. But in many cases, it's a long and winding road without any resolution. And I think that's quite a nice little way of looking at it. But often migraine is on the change. We sometimes need to be a little bit cautious if there's a very, very significant change. We might think, is there something else going on in the brain? But that's very, very rare. But it's not uncommon for migraine to change. The end of the story, the end of the long and winding road, usually is that migraine does get better as you get older. But once you get through the menopause, so we always have a bit of a discussion saying, and Katy corrected me, she will again now. I said the only thing in my career that I've seen gets better with age is migraine. Everything else gets worse.
And I say the other thing is that you get better at being wise.
Yeah, so there's two things, wisdom and migraine.
Wisdom increases.
But as I said earlier, there's no black and white in medicine. We can't say migraine always gets better with it. So there are some people, unfortunately, in their 80s and that, but it's very unusual. So you can be optimistic that with age things, but why wait till you're 70 to get your migraine sorted?
Well, the other thing, the other reason for optimism is that we are getting new treatments, which is why I've stuck that up, so we don't forget to tell you about those.
You want to make a comment in the front here?
Well, it was just hearing what you're saying about menopause, but is there a sort of female hormones, but is there a different journey from male and female?
Well, that's a good question. Katy's the hormone queen. She's going to be making up hormones. We haven't studied male hormones that much, to be perfectly honest, because migraine is is more common in females. It's very obviously a hormonal situation in many people. So
if you're a male,
males, if you're male, testosterone doesn't cycle quite so much. It's not so influential on migraine. I'm not sure that we know too much about that, Katy.
Well, I think that brings us on to how I normally start explaining migraine when I'm seeing patients in clinic, which is we know that it's genetic, but we know that the genes can be quiet throughout your life until a combination of things occur to activate those genes to start you getting migraine attacks. And so the genes set the brain always to be a bit more sensitive to change. So I think understanding the key word is change. So if you think about what was changing in the few days or around me getting a migraine attack, why am I now getting them? And it might be a whole combination of changes, and they can change themselves from attack to attack, and it can change throughout your whole life. So we do see even quite young children. My youngest patient started having migraine attacks age 3. We see a peak around early teens, and that is, if you think of the things that change in your early teens, it's not just hormones, but of course puberty is a big one. Often kids have changed school. They've got changing friendships. They may have stresses. They may have excitement because they're taking on new things. They may be very sporty and start doing lots more exercise and training. They may actually need more sleep, but don't get more sleep because as a society we make them get up and go to school at an hour in the morning, and then they have a lie-in at the weekend. So changing patterns of behaviour can add in, as well as hormones. So I think thinking about managing migraine as you go through your life is thinking about how can I make my life a bit more routine, how can I keep change to a minimum. And there are certain peak times when changes in hormones are particularly contributory to worsening migraine attacks. So puberty is the first one. When you're a female and you're having a regular monthly cycle, that fluctuation in estrogen levels is really, really important. I've also now added to my tactics for helping people with migraine attacks in the perimenopause. Anybody from the age of 30 sort of 5 onwards, I ask about perimenopausal symptoms because we know that the perimenopause can go on for years and years. The estrogen levels are fluctuating wildly, and it's a big irritant for the brain. So that, getting the hormones right is one of the preventive things, and smoothing out those changes. But there are simple things that people can do for themselves. So eating regularly, low GI foods, having a nice smooth blood sugar throughout 24 hours, your brain will be a little step away from the threshold. If you go to bed at the same time, you wake at the same time, and you have good quality sleep, your brain will step away from the threshold. And doing regular small amounts of exercise can be helpful. So anything that you can do in terms of lifestyle management can help. And it's never about finding that one thing. So when we talk about diet, people say, well, I've excluded this and I've cut out all these different things. And actually it's more about making sure that you're eating a good quality diet. The way that all the nutritionists are talking about diet now is the way that I counsel people about diet. So you need to be having lots of plant-based foods, not too much processed food. You need to be eating small regular meals and maybe a bedtime snack. Lots of healthy fats and protein to give that slow release energy. Lots of oily fish because then you can boost up your omega-3. And keeping the gut healthy seems to also help keep the brain healthy. So there's a lot you can do. But even if you do every single thing right, you may still get migraine attacks. So going back to what David was saying, it's not your fault. You're not a failure. You've just got that genetic background that makes your brain more sensitive to sensory inputs and change. And I notice you're wearing glasses. We can talk about light sensitivity. Light sensitivity often persists throughout, even between attacks. So people will say, well, when I'm in an attack, I have to go in a dark room and I have to switch all the lights off. But even in between attacks, I don't like the glary sun. I don't like the light flickering. And there are a number of lenses. I won't go into all the different ones now, but if you want to chat afterwards as to what would be a good lens to prevent the light sensitivity. Wearing sunglasses all the time can actually make it worse because your pupils dilate, and then when you take them off, you're even more light sensitive. So that's quite an interesting topic, actually.
And just to really reiterate that, the difference between triggers and things that change sometimes get a bit confusing. So classically, you know, cheese, chocolate, red wine are the big things that trigger off migraine. There are lots of triggers as well that people have. And some people have spent a whole lifetime looking for this elusive magic trigger, which you're not going to find because it's very rare that there is one. There may well be one. So there are triggers that say, bang, off goes the generator, goes the trigger, fires it chemically. But as Katy said, there's also things that change, and this is what people don't realise, that migraineurs are far, it's far more important to keep things constant because migraineurs' brains don't respond to changes in sometimes the low pressures coming in off the Atlantic or anything that's changing. So I think triggers and things that change are important. Now the other, I just want to reiterate what Katy said about they're not always constant because all these things, the triggers and the changing things, are interacting in a complex network. It's not a simple relationship between inputs and outputs or cause and effect. They're all interacting in this dynamic network that's non-linear, which are changing with time. So sometimes something might work, sometimes another thing might work. But all we can do is keep things constant, avoid triggers if they're obvious, and have a healthy lifestyle. Because this all feeds in, the gut biome is really important. It all feeds into this really complex network that is known as our brain. But keeping things constant, identifying any triggers if you've obviously got any and avoiding them is a really useful first step. Exercise is important, healthy diet is important.
Chocolate got a bad name because a lot of people crave chocolate in that prodromal phase, that couple of days before the migraine attack fully hits and you recognise it. So they would crave chocolate, eat chocolate, and then get the headache impact stage. And actually some studies were done about this to see if it was truly the chocolate that was causing it. And the good news is you can eat chocolate because it's just a warning sign that you're getting a migraine attack if you crave it. So there's very little evidence that chocolate is actually a trigger. Now, some people, there's always, whenever I say things like this, there's always somebody that says, no, for me, every time. And I think that's the key thing. If you have something that every time you eat it, you get a migraine attack, clearly don't eat it. It is a trigger for you. But in most people, they say, well, sometimes they can and sometimes they can't. Then that's not really a real strong trigger for you. It's about other things that are probably happening. I have a friend who said to me, every time I eat a satsuma, I get visual aura within an hour. She doesn't eat satsumas anymore, so that's fine. But most people, I think sometimes people concentrate too much, as you were saying. So they're going, I've got to find the one thing and then I'll be magically better.
Katy, time's moving on. We tend to prattle an awful lot without. So I'm going to look at the board and see where we are. Let's take a check where we are.
We've done triggers.
We've done triggers. Have we done hormones enough, do you think? We probably have.
I mean, I can always talk more about hormones.
Otherwise Katy will go on all day, so I'm going to say we've done hormones, actually. What are we going to do next?
Can I ask a quick question about hormones?
Yes, of course, yes.
So, if it looks like it's the migraine attacks are linked to hormones,
yes,
and generally you're doing all the things that are kind of good for it, what else can you do? Would
so
see a doctor and...
Yeah, I mean, there are a lot of things. If you are having regular periods and you're needing contraception, then you can use contraceptive pills to smooth out the cycle so that you're not having periods by taking several packets back to back, or there's a progesterone-only pill that you can take that seems to help as well. Just a word of caution, if anybody has migraine with aura, we don't advise that they have contraceptive pills with estrogen in, because there's just a slightly increased risk of stroke with both of those things. So migraine with aura and with the oral contraceptive, you've put the two together, then it's a no-no. So once you get into the perimenopause, it's about looking at HRT, and HRT, there's a whole discussion around which HRT is the right one for you. But the bottom line is basically to get some safe HRT, which is absorbed through the skin. So the transdermal form of HRT is the best form for anybody, really, even if they don't have migraine. And that can give a nice smooth blood level of estrogen. So you can get that by gel, by spray, or by patches. And you will need to, if you still have a womb, then you still need to have protection of the lining of the womb, and that can be done by a coil or by taking a progesterone tablet. So that needs a headache specialist, menopause specialist, combined clinic, which I'm very happy to say we have a lot of at the National Migraine Centre. A lot of clinics now who are doing menopause will be seeing a lot of people who have migraine as well, so they are beginning to, but it does frustrate me sometimes when people are, you know, on the telly talking about perimenopause and menopause and they don't mention migraine. So it's so common. So I'm popping them up wherever I can go and don't forget migraine.
Just to clarify, because we use this terminology and expect everyone to know what it is, perimenopause means the time around the menopause, whereas the menopause means absence of menstruation. So that's, you know, that's the difference.
Yeah.
Let's move on. I'm going to pick up that one, medication survival headache. I think probably next is an important one. So chronic migraine, anyone can get medication, let's call it medication survival headache, but it's very common in people with chronic migraine because you will get medication survival headache if you take any painkiller or anti-inflammatory on more than 15 days of the month, or any Triptan, which is a migraine-specific acute medication, on more than 10 days of the month. So virtually most people with chronic migraine will be taking too much painkillers. Chronic migraine, just to remind ourselves, is headache on 15 days, an arbitrary definition, but headache on 15 days or more of the month, of which 8 are or more are migrainous. So what is medication survival headache? Well, we don't actually understand why we get it. I think what we think is that this excessive painkillers or these excessive anti-inflammatories or the excessive triptans sensitize the brain even further. So by taking too many, you're actually making things worse. I think most people have a sense that they're doing something not quite right, but they do need these tablets because they've got an important meeting at work or their kids are going to be picked up from school. So they get into this sort of cycle of, yes, I need to take my painkillers to survive, but I think I know at the back of my mind this is not the right thing to do. So you won't move forward until you really get you come off them, or you certainly get your intake down to below those amounts. So you really need to be on a good medication, preventive medication, or get your migraine under control to come off these analgesics or triptans.
The worst thing to take is codeine, because that very quickly pushes the brain into a more irritable state. Also makes the nausea and vomiting worse, it's addictive, it's generally a bad thing, it hits the wrong receptors. It's good for acute pain, so if you have an operation, it can be really helpful. But if you're having recurrent episodes of migraine, it actually is the worst thing, and it's a bit of a hobby horse for any headache specialist to be saying, please don't go into the pharmacies and buy things with codeine, because you can very rapidly get yourself into big trouble. So we should, as doctors, be saying to anybody that we're advising about using acute treatments, don't take the triptans or those painkillers too often. If you find you're having to, we need to have another conversation with you about what else we should be putting in place to limit your need for those, so that it's less than 10 days a month of the triptans.
Yeah.
Get a little bit more flexible with the painkillers like aspirin, ibuprofen. Should we talk about acute treatments?
Well, let's talk about treatment altogether. Yeah. Let's move on into the treatment bit now.
Yeah.
So we talk about that. Let's move on to. So just to clarify, acute treatment means, because we use these words like acute and peri, and we assume that everyone knows what we mean.
Yeah.
So acute treatment is like rescue treatment. You're having a migraine, you need to take something right now, acutely. And I'll pick up the sort of pre-triptan stuff, and you can do the triptan stuff. So before we move on, you might have all heard of triptans. This has been a huge breakthrough in the mid-90s for migraine acute treatment, but there are other things we can use. You can use something simple like paracetamol and aspirin, and these work well in some people. Paracetamol for its pain-killing action, aspirin for its anti-inflammatory. Aspirin is a really useful anti-inflammatory medication, and migraine is an inflammatory process. You get the pain because the lining of your brain is inflamed. There are no actually pain fibres in the brain itself. You can chisel away at your brain without any problems at all. It's the lining of your brain that's problematic. So you get inflammation at the lining of the brain, so aspirin can be quite good for that. And if you think about it, there's nothing in your bloodstream. You've got to get up to a therapeutic level quite quickly, so I always suggest 3 soluble paracetamol, 3 soluble aspirin. These are big doses to get you up to this level quite quickly, with something to help this gastric stasis, this gastric problem. And you can now buy Bucostem, which is a very useful medication for dampening down the nausea and helping this hold up in the stomach. You can buy that over the counter. So this combination is a really useful combination. You can buy yourself And it can sort your migraine out in many people if you take it early enough. But if it's not working, you can then go on and take the triptan. So 3 soluble aspirin, 3 soluble paracetamol, a couple of Buckostem, and there is some suggestion that they work better with a fizzy drink. It probably absorbs, changes the acidity of the stomach a bit, it increases absorption, and they work slightly quicker. So you can use that with a triptan, you can use that before a triptan, you can find out just what's the best for you during each attack. So that was probably one of our sort of basic mainstays of migraine treatment. In the mid-90s, there was a very big development, significant development. There's been 2 really big, significant developments in migraine management. One was in the mid-90s, one was just a year or 2 ago, which we will also pick up on the preventative side. But in the mid-90s, we had our first designer migraine drug. The medical scientists worked out the pathway of migraine, and they worked out how to block it with this group of drugs called Triptans that we use for the acute management of migraine. And this was a very big, significant development. And I think anyone with migraine should really ideally have the ability or availability of using a triptan. So Katie will now move us into the triptan field.
Just a word of caution, of course, whenever we're talking about medications, you have to be aware that you are safe to take those. So if we're saying about aspirin, but you have gastric ulceration or you're on a blood thinner or something, do need to check with your GP. So make sure that those medications that we're talking about in all of them are safe for you if you're in any doubt. So going on to the triptans. So these are amazing medications in many people, and there are 7 different ones. The one that everybody tends to get given first is called sumatriptan, and that's available over the counter as Imogran, although it's quite expensive, I think. So sumatriptan was first given to people in injection form, but it's also available as a nasal spray and also as a tablet. One of the things I hear in clinic very often is that people take sumatriptan, it starts to work, then it wears off and they fall asleep. So they feel quite groggy for the rest of the day, and what we're really wanting is something that gets rid of your migraine attack as quickly and with as low side effects as possible so that you can get back into functioning. And that's, I think that's the goal of the treatment really, is to get something rapidly to make that impact lessened. So if you have tried sumatriptan, you may have been given 50 milligrams or 100 milligrams as a tablet, and sometimes people are told, oh, it's a really strong one, don't take it too quick, only take it if you get a really bad attack. And that's actually the wrong way round. It's much better to take your triptan medication quickly if the things that David described haven't worked for you. So don't wait. Think of your migraine as a snowball gathering momentum and squash it when it's small, rather than waiting until that attack is full blown and you've missed the boat and nothing's really working. Yeah.
How do you navigate the compound migraine, so taking too much sumatriptan but also getting it when it still works?
Well, that is the tricky decision, and that's where, if you're having chronic migraine, getting a good preventive in place is better, so that you're reducing the number of days that you have to do it. So we'll come on to that in a bit more, I think. One of the things I say to people who are trying to control their triptan use is it is up to you to decide what the scenario is for the day. So if you've got a day where you think, oh, I haven't really got anything planned, and usually the aspirin or the ibuprofen or the paracetamol will at least take the edge off and you can push through, then you may have to do that sometimes. But if you've got a day when you've got something really important, then you have to take the triptan. But there are other new medications which may make that decision even easier because they don't cause medication overuse headache or medication survival headache. So sumatriptan, the maximum daily dose is 300 milligrams. So if you've been given a packet of 50 and you've got a packet of 6 of the 50 milligram tablets, theoretically you could take a whole packet in one day quite appropriately, and your GP will go, wah, because a lot of GPs don't realise that actually that is the dose for sumatriptan. So if you had 4 migraine attacks in a month you wanted to treat, you might need 4 packets, but probably what you need is a better triptan. So my advice then is move on to one of the other ones. There are 2 that have nasal sprays. Sumatriptan nasal sprays absorb through the gut. And the milk formulations are available, but they're also absorbed through the gut. They're quite convenient. You don't need to take a big meal with them or a glass of something, so if you're feeling a bit queasy, a milk formulation can be convenient, but it's all still absorbed through the gut. The zolmitriptan nasal spray is 30% absorbed through the nasal lining. So that can be really helpful if you want some really quick, effective rescue treatment. So think about what you're trying to achieve in that day. Are you needing to get back into your activities quickly? Or you may be somebody who gets, we know that often menstrually related migraine will roll on one day after another, so 3 or 4 days in a row, and the shorter acting triptans may wear off and then you have to take it again and again. So you may do better to have something like Preventative or Naratriptan, which are longer acting. So they broadly fall into 2 groups, the short acting ones, of which there are 5, and the longer acting ones, of which there are 2. So it's worth having a discussion and perhaps listening to our podcast episode on triptans to get a much clearer idea of the nuances of how to use triptans properly for yourself. And that makes me sort of say my little mantra, which is that you need to find the right recipe for you, because nothing works for everybody. Everybody with migraine is a bit different, and so I will have some people who come and say to me, oh, I've found X triptan, whatever it is, and it's a fantastic one for me, and somebody else will say, well, I tried X and it was rubbish, didn't do a thing. So that's the frustrating thing about migraine. I think there's no test. We can't look at you and go, ooh, you look like a zolmitriptan person. If only we could. I think with the research on pharmacogenetics, one day we may have a little cheek swab, send it off, no, you need to try that one. But we're quite a long way from that.
Sorry, and I guess that's further challenged by the changes as the years go on as well.
Yes.
Different types.
Definitely.
I think, just to pick up on a few points, if I may, Katie, it's really important to rotate through the triptans until you find one that's right for you. So many times we see in clinic people that tried one from their GP and it hasn't worked, they said, well, that's it. So really insist the GP tries different triptans, because they're all really slightly different. We all have slightly different brain characteristics. The other thing that just worth mentioning is the injectable. You can get sumatriptan injection. So if you're really vomiting really profusely, or particularly if you wake up at night. So if you wake up at night, that migraine snowball, if you like, or generator is halfway down the line. So sometimes an injection is useful at night time if you wake up at night, because it's unlikely that oral is going to be very effective, so don't be afraid to use the injection. One of the problems with triptans is they can cause, in some people, constriction of the blood vessels. So if you have any angina or any problems with vascular disease, you can't use them. And the other important thing is they're not licensed for people over 65. Now the reason for this is because as you get over 65, I'm afraid speaking here, our arteries tend to get more furred up, so it's always slightly more, not dangerous, but there is slightly more risk of taking a triptan. And the fact that most people over 65 don't have migraine, the pharmaceutical companies haven't done the big studies that they need to market these drugs over 65, so they're not licensed. Doesn't to say that you shouldn't be using them, and in many cases we actually do use them, because the benefits of these drugs in people over 65 far outweigh any minor risk. So just a couple of caveats to go with triptans, but there's a whole new group of drugs. We won't confuse the waters too much at the moment by mentioning CGRPs for acute, but there's a whole new group of drugs coming in that might be a useful alternative to triptans, and we'll be seeing some of those in the next year or two. Anything else about acute medication before we move on? So that's your rescue stuff. Okay, everyone happy about that? So let's move on to preventative medication. So preventative medication is something you take every day, whether you have a migraine or not. And a lot of people don't like taking tablets. You have to take a position on this. And let me just say what I'm going to say is a few basic introductory things. I'll say a bit about our traditional treatments, and then I'm going to hand over to Katie to say something about the really exciting new developments that are just coming into the market, if I may, Katie. So what do we say about prevention? So first of all, we've got a number of questions to ask. Who do we give prevention to? Well, there is no hard and fast answer. The textbooks say 3 or 4 times a month if you have a migraine, but I don't think that's right. It all depends on the impact on your quality of life. Some people might have 3 or 4 attacks a month. They don't want to take a regular medication, and they got quite good control with their triptan. That's absolutely fine. I have one person who I see in clinic who has 1 attack a year, and she is desperate for preventative medication because during that attack she's in hospital for 2 weeks. She's on a trip for a week, and she's totally paralysed. And yes, please, I'll have prevention for 1 attack a year. So there's no hard and fast answer. You have to have that discussion with your GP about the impact on your quality of life. I think it's important to be on any preventative agent for at least 6 to 8 weeks before, at a good dose, before you say, it's not working again. So many people we have in clinic, I tried beta blocker for 2 weeks, it didn't work, so I stopped it. You've got to give them a good try for at least 6 to 8 weeks at a good dose. When you found something that works, how long do you stay on it for? Well, that's a totally open-ended question. Minimum of 6 months. But for some people, they obviously want to be on a lot longer. If you've had a huge impact on your life with migraine, then you can want to be on preventative medication. But there's no harm if you weaning yourself off and see what happens, but you need to be on it for at least 6 months. So those are some basic introductory observations. So next question is what we're going to use. So traditionally, until very recently, all our preventative medications were found serendipitously. That means they were found totally by chance. Someone was taking a beta blocker for blood pressure and said, hang on a sec, my migraine is better. Someone with epilepsy was taking an anti-epileptic tablet, hang on a sec, my migraine seems to be better. So this is how we found out about preventative medications until very recently. So what do we have in our cupboard? Well, beta blockers, there's really 3 groups, and we've added another 1 or 2 recently. So the 3 historic groups were beta blockers. You've probably all heard of these, Propanol is the mainstay. A group of tricyclic antidepressants. These were initial antidepressants introduced in the 60s and 70s. Amitriptyline being the one we tend to use, and a lot of people don't like using it because they go, it's an antidepressant, I'm not depressed. That's not how we're using it. So we have beta blockers, we have amitriptyline, and we have anti-epileptic agents, of which topiramate, you may have heard of, is the one with the most evidence. So those are our 3 basic standby traditional medications, to which we can now add candesartan, which is an anti-blood pressure drug, which is used quite commonly, and more recently again, Botox for chronic migraine. It was observed that people having Botox for their cosmetic procedures, their migraine was getting better, the trials were done, and for chronic migraine, Botox is effective. So those are our 4 serendipitous traditional preventative medications, most of whom do have side effects in some people, there's no doubt about that. It's always this matter of weighing the side effects up against the efficacy. There's been a big development in the migraine field in the last year or 2. So just as in 1995 we had the first designer drug for acute migraine, since 1995 the search has been on for a designer drug for prevention of migraine. And of the 14 compounds that were started to be looked at in 1995, and this just gives you an indication of how long it takes to develop these drugs, 1 has made it to the final hurdle. This drug is now available on the NHS. It's a group of drugs called calcitonin gene-related polypeptides, CGRP for short, and Katie will now introduce us to this whole new exciting development.
I will. So, calcitonin gene-related peptide is a neurochemical. So it's been found that that is a very important protein in the brains of some people with migraine. And as I said before, nothing works for everybody. So it's not everybody with migraine, but many people with migraine, this is one of the most important chemicals that triggers attacks. So researchers have been looking at how they can block it. The first thing that they found was that they could create an injectable drug called monoclonal antibody injections. So these are injected by a patient themselves using an auto-injector once a month, and what happens is the antibody binds to that protein in 2 of the injections, or there are 2 others that it binds to the receptor. So it blocks that pathway. And in some patients, we hear the words life-changing now in clinics. So it's been approved by the NHS and by the Scottish Medicines Consortium that people who have tried the more traditional preventers that David was mentioning and who haven't had success with those, if they've tried 3 of them and given them quite a long period of a good dose and they're still really struggling with their migraine attacks, they may be eligible to have these anti-CGRP monoclonal antibody injections. Now, the NHS, as you probably know, is struggling a wee bit at the moment, and also new drugs tend to be really expensive, and also there are many, many people who may be eligible for these drugs who are beginning to hear about them. And so we already know with the impact of COVID and the strain on the NHS that it is a struggle to get referred to neurology departments, and each individual health board has to make its decisions about what services they're going to set up and how they're going to provide things. So just because something is approved doesn't necessarily mean that it's easy for you to get it. And this is where frustration arises. And some people we've heard, even just a couple of days ago, have managed to get these monoclonal antibody injections privately, transform their life, but they can't get it on the NHS because it's not approved in the area that they live in as yet. So it is worth being aware of these because I think these will come more and more over the next few years, and I think they're very hopeful. The other group of medications, so the ones I've just mentioned, there are 3 that you can inject yourself, and there's one which is an infusion, and you have that every 12 weeks, and that tends to be people who arrive in hospital with a thing called status migrainosis, which is where they've had a relentless migraine attack that nothing's worked for, and they've had it for more than 72 hours, and it's just not going away. So the other group, which are very exciting as well, is a group of medications called the GPANTs. The GPANTs were originally trialled and they had some issues, and then people started getting problems with their liver, and so researchers carried on looking into the GPANTs and have now found several drugs which don't cause any liver problems, but also which seem to work very beautifully. You take them by mouth. They can be used, some of them are used as preventers and some are used as acute treatment, and there's one which is licensed for both. That is a medication called Rimegepant. One of the lovely things about Rimegepant and the GPANTs generally is they don't cause medication overuse headache. So if you're trying to monitor your triptan use, then having an option which is going to work for your acute headache but which isn't going to aggravate your headache is really a step forward. The other nice thing about them is that even if you're on the injections, monoclonal antibodies, you can still take a GPANT for your acute medication. But you can also take Rimegepant as your preventer, and you only need to take it on alternate days. So there's a lot of exciting developments, and we've been prescribing Rimegepant since March in the National Migraine Centre. We have to charge for it because it's an expensive medication and we're a charity. But people are coming back to us and saying, I'm really happy with this, can I have some more? And we're beginning to see the approval bodies, NICE in England, Wales and Northern Ireland, and the Scottish Medicine Consortium are deliberating about who will be enabled to get these on the NHS. And we've heard that in Scotland, if you have tried 2 triptans and they aren't working for you, or if you have one of the contraindications like the cardiovascular disease, then you can ask your GP, would I be able to get a prescription for Rimegepant? In England, NICE has said, well, we're only going to approve this for prevention of episodic headache, episodic migraine. But I think there's also, keep your eyes and ears peeled for the news, because I think there will be changing availability of these things, hopefully making them more available over the coming months and years. And they are, going to be a game changer. I was at a symposium the other day where a couple of professors, headache specialist professors, were using the terms, this is a paradigm shift in the way that we treat migraine headaches. So I don't think they're going to go away, and I think they're going to be a very exciting way forward, which is lovely.
I think it's fair to say, that just to add to what you say, we're going through a transitional phase at the moment, so they're out there. Most GPs have never heard of them. The availability is you need to be referred to a headache specialist or a neurologist, and we know that there's a long waiting list, lots of people with migraine. But if you failed 3 preventative medications, then in theory, it is your right to be asked. You can go to see a neurologist, you can ask to go and see a neurologist for consideration of these new drugs. I think in the next year or two, GPs will be prescribing them, but that will take a wee while to happen. At the moment, the main problem, the barrier, is cost. These things are about £300 a month, and if you think of how many people benefit from them, we're talking about billions of pounds a year to the NHS. But all these new drugs come in, they start off being very expensive, but they very quickly come down in price in time. So it's an exciting time. You need to know about them. You need to make sure your GP knows about them. And if you've tried 3 preventative medicines and they haven't been successful, then you should ask to be referred for consideration of CGRP antagonists.
So, I don't know if this is maybe the moment just to, if you've got anything to say on like alternative, like acupuncture.
Yes, we're going to go into that next. Thanks for introducing us to the next. So we've done, that's drugs, okay? So we've done drugs. Let's do the rest of the stuff. Now, as Katy, I think, said it earlier, it's not, everything doesn't work for anyone and there's no magic, but some things might work well for some people. I'll talk about needles and then Katy can talk about electrics because she likes electrics. So needles, acupuncture, yes, there's evidence to support acupuncture. NICE, the English body that looks at decisions in healthcare, said acupuncture should be available on the NHS for people with migraine. You try getting acupuncture on the NHS, you might as well forget about it. But acupuncture has got a benefit. The other needles approaches we use are what's called occipital nerve injections. When you get a migraine, you might notice that these 2 big, in these grooves at the back, that's quite, you like to rub that, but they're quite tender here. Tender at the moment, probably, if you have a migraine. So one option is to inject a bit of cortisone and local anaesthetic in these areas, and that can dampen things down for 3 months or so. Again, it goes back to this vomiting and booting the migraine centre. I think what that does is boot the migraine centre back to normality a little bit. So those are needles. Katy likes her things that go zip.
Sorry, just before you do that, when you say acupuncture, if you were going to speak to an acupuncturist, who should you look for?
Well, that's a very good question, and therein, of course, lies the rub, and that's one of the problems of looking at the scientific evidence, because there are different types of acupuncture. There's traditional acupuncture, Chinese acupuncture, all sorts of acupuncture. So I can't answer that question because the scientific evidence is all over the place, because there's so many different types of acupuncture.
So the evidence isn't all about one kind?
It's quite practitioner dependent. We have 2 podcast episodes about acupuncture, and the people who are the guests on the podcast have come to acupuncture via different routes. One has done a degree in acupuncture, and one is a doctor who has done a lot more training in acupuncture, and they talk about how do you choose somebody. So it might be worth listening to that. But I think what we generally feel is that if you're going to have acupuncture, again, it doesn't change things quickly. You need to have it at least once a week for at least 8 weeks. And if you can find somebody who says that they have an interest in headache and management of migraine, then that is one way forward. There are societies that you can go to see where registered acupuncturists are.
It's such a...
It's a minefield. Lots of people will take your money for migraines. A lot of people with migraine are desperate. I'm sure you're aware of this. You'll go try this, that. Some people will cut bits out your skull, and some people will do all sorts of stuff. So you've got to be... It's a bit of a minefield. Online is a total minefield. So really you've got to go, I'm afraid,
go to one of the
where the evidence lies, or look at our website. The Exeter Headache Clinic's got a lot of information. Katy's stuff's got some fantastic podcasts. So go to sort of reasonably, well, you might not think we're sort of reasonably kosher, but I think we are, aren't we?
I hope so.
Talk to us about electrics.
Yeah, well, I'll come on to electrics, but I think, as we're on the acupuncture, I think alternative therapies can be helpful. So we've also done a podcast episode with a hypnotherapist, and that brings me on to sort of managing stress and mental health and anxiety, which I think is also contributory to some people's migraine attacks. It's not the whole story, so don't let somebody tell you, oh, it's probably just stress. It sometimes is a contributory factor, but it's never just stress. So thinking about techniques by mindfulness or yogic breathing or meditation in whatever form, whatever works for you, to try and calm down. And what we're doing basically is resetting cortisol and adrenaline and just calming that physical kind of effect of stress. So one of the ways of doing that is neuromodulation devices, and these are interesting ways of soothing the brain. The one I'm holding up is called a cephalejewel. So this is a little diamond-shaped thing. It used to have prongs on it. It looked really Star Trek-y, but now it looks a little bit more Wonder Woman. That's why I think I look like Wonder Woman. So you basically stick a little gel electrode on your forehead here, and you magnetically it attaches like that. You switch it on, and you have several different programs, and I encourage anybody, if you want to try this, read the instruction manual carefully. So the first one is for acute treatment, so this is another option. So you can stick it on. If you feel migraine attack coming on, you press the button once, and it gives you an electrical impulse over your forehead, and that you sit there quietly having that for about an hour, and it can often take the edge off. It's quite soothing if you control the intensity. If you let it rip, then it goes up to the top, and you might be sitting there going, oh my God, why did she tell me? So when I was first advising patients to try these, a lot of them came back and said, oh, I couldn't bear it, because they didn't take control of the intensity. So you press it once, wait for 30 seconds, press it again, and you'll then get intensity control, and then you can put it up to the level that you're comfortable with. If you press it twice, you will get a program which you can use for 20 minutes every day as a preventer. And I had a colleague who was a headache specialist working with us, and she actually introduced me to how beneficial she found this. She said, I just use it every night for 20 minutes. I love it. And it relaxes me, and I just feel soothed. You do have to use it regularly for quite a number of weeks to get that preventive effect. But it's safe. It's not a drug. You don't have to swallow it. The trouble is, it's quite expensive. So what I have here is another version, which is a Lloyd's TENS machine for migraine, which is virtually identical, quite a lot cheaper. So yeah, have a look at those. The other sorts of neuromodulation devices are coming, but they're not very easily available here in the UK. There's one which is a magnetic pulse machine, and some headache specialists will advise this. This is called the STMS Mini, and it sends magnetic pulses over the base of the brain. It's not very easily available. It's quite expensive. There's one called, in America you can get one which you wrap around your arm, called Nerivio, and that sends impulses up the peripheral nerves. And we may get that here in the UK, but it's not available at the moment. So I think these novel approaches to managing migraine attacks, people are looking into it, researching and trying to find alternative things. One of the labels here that we haven't talked about, and I usually talk about this when I'm talking about diet and sleep, and somebody asked about supplements. So I'm a big fan of doing everything that you can do that doesn't involve swallowing toxic medications. So supplements can be quite useful. I mentioned omega-3. There's a small amount of benefit for people taking a high dose of omega-3, and it's a safe, good thing to take generally. Vitamin D level, especially in Scotland, get that vitamin D level up, because gloomy, cloudy days in the UK, we don't make vitamin D, and there's some evidence if you have episodic migraine and low vitamin D levels in your body, you're more likely to progress onto chronic migraine, and it's generally a good thing to have enough vitamin D for your bones and immune system and all sorts. But more specifically, the migraine supplements that we advise, which some people have done research studies on, are magnesium, vitamin B2, riboflavin, or coenzyme Q10. Now, you have to find the one that suits you. You need to take them at a reasonably high dose for at least 3 months before you can decide. Like everything with migraine, if you take them for a week and nothing has changed, you haven't taken them for long enough. Magnesium it's complicated because there are lots of different salts of magnesium. The one I normally advise is either the citrate version, but that is quite laxative, so just be careful, or the glycinate form. And between 400 and 600 milligrams every day is the generally advised dose for those. Vitamin B2, 400 milligrams a day for at least 3 months. And be careful because that turns your urine bright orange. So I do warn people, because I had a friend who freaked out when that happened. No, that's normal. And then the third one is coenzyme Q10, which is the most expensive, and you could take 300 milligrams a day. We don't know whether it's better to take 1 or 2 or all 3. So that's really a matter of personal choice.
And the evidence is difficult. I mean, the problem is all these things that we're talking about, and I'll just say a little bit about diets as well, it's not supported by good scientific evidence, because these trials are really expensive to do, and all the trials are dominated by the pharmaceutical industry, because they're very powerful, there's lots of money in these drugs. So all these things that we're talking about now, we're getting to the bit of the sort of flaky end, you might like to say, of the migraine management, are not supported very well by lots of hard scientific evidence. Probably the best evidence goes with this thing called coenzyme Q10, which is a naturally occurring, if you like, it's like a vitamin. You can buy that from health food stores, and there are 2 small trials to support that. So I think Katie's right, it's worth trying these things. The other thing is people have talked a lot about a diet, so high omega-3 diet is one thing that people try. Ketogenic diet is another thing, you can find all these diets online. Sodium diets, manipulating your sodium. But all these things are not supported by rigorous scientific evidence. And the other thing is there's awful lots of stuff going on. Well, what I'll try magnesium, and I'll try a salt diet, and I'll try acupuncture, and in the end you're thinking, well, what's working, what's not working? So it's probably best to just try one thing at a time, or just what is right for me, what do I feel is the right thing for me to try first, rather than throw the book at you. If I just pick up on going back to holistic stuff, if I may, just very quickly, I'm getting quite into this holistic side of things, it's particularly with people with chronic migraine and all this other stuff that goes with migraine. Because there's a lot of stuff that goes with migraine: anxiety and depression, bowel problems, fibromyalgia problems, sleep problems, or mast cell activation, which we better pick up on in a minute. But there's a lot of stuff that goes with migraine, and in many people, I think this is due to stress that builds up in the body, because every time you get a migraine attack, it's an inflammatory response, and this inflammation builds up and up and up. All the other stresses in life that you get builds up this inflammation. So ultimately you get all this inflammation that's building up in your body and overflows, causing all these problems: brain fog, lethargy, anxiety, depression. And I think the important thing to realise is a lot of this is actually held in the body. We've always historically thought the mind was separate from the body and it's all up in the mind. But actually no, we're coming round to the fact now that all this stuff is embodied, it's held in the body, and then the mind and the body are all better seen as one unit. And I think we have this intuitive feeling that this is correct. I broke my heart, I've got a gut feeling about it, I feel it in my bones. So we've got this intuitive feeling as humans that actually we're far more embodied than we think we are. And I'm coming much more round to the approach that a lot of this chronic stuff, particularly chronic migraine and all the other stuff, is due to stress that's held in our body. And I think these holistic approaches, these mind-body approaches, can be very useful. They're not the actual answer, but they can be very useful. Relaxation therapy, breathing therapies, mindfulness, got a lot of time for. And this is winding up to a bit of a plug here, because I'm working with this really interesting yoga teacher in Exeter. She's a holistic healer, she's a Reiki healer, and we're trying to develop a joint approach. Yes, drugs, great, it's a dual track approach. We're not saying don't use drugs, but we're saying have a think about what feels right for you, drugs, but also holistic approaches as well. So if you'd like to know a little bit more about this sort of program we're trying to develop, we're doing a few workshops. And on the right, on that piece of paper on the right up there is a QR code, or if you can't do that, just let me have your email address. And we're going to be doing some Zoom workshops where I'm going to be talking a bit about more of the traditional stuff, and she's going to be talking more about the holistic mind-body stuff. And I think there's a big role for that in all this stuff, not just migraine, but a lot of other stuff as well. That's my plug. That's my rant. Holistic medicine.
I think we have to have an approach that encompasses a lot of different, maybe small changes that will add together to move that threshold away. That's why it isn't just about one thing. I think we'll go on to mast cell and link comorbidities, which is basically all part of the understanding, I think, that it's so complex. The brain is very complex, the interaction with the body is very complex, and we are, what I've been surprised about is the number of patients who come in to see us in clinic and they say, and I've also got hypermobility, and I've also got postural orthostatic tachycardia syndrome, which is where people stand up and their blood pressure zooms down to their boots, very often linked with hypermobility, and sometimes a condition called Ehlers-Danlos syndrome, which is beginning to be increasingly recognised. They often also say, and I get allergies, I have food intolerances, or I get hives, or I get gastric acid. Some of them get asthma, some of them get irritable bowel syndrome, and often we find that that is a thing called mast cell activation syndrome. So mast cells are the cells in our body that are present all over our body, and when there's a challenge to our body, they release histamine. And histamine, so if you have a nettle sting, then you get a big red flare, and that's histamine coming through. And we know that as women go into the perimenopause, they become more histamine intolerant. So it's often at that time of life that they start to really find problems with itchy skins or allergies or other things, and their migraines kicking off. And so we don't fully understand it. There is still a lot of research to be done about mast cells, but one of the things which has almost helped us on the way to getting more research is the onset of COVID, because COVID's infections have sometimes left people with reactions very similar to mast cell activation syndrome. And so people have suddenly started saying, well, hang on a minute, what's going on here? And so I think more and more people are looking at the sort of intracellular changes which may be contributing to inflammatory responses to migraine inflammation, and why are these things so commonly seen together? The other things we see more commonly are people who are neurodiverse. So we see a lot of people who also have autism or ADHD. We see people who have other medical conditions like celiac disease, so that's more commonly associated with migraine as well. And then things like fibromyalgia, chronic fatigue syndrome, and ME. And so I think it's not useful for us to be saying, right, you need to see the migraine person, and you need to see the person about that, because things are all interconnected. And what we lack, I think, at the moment in the NHS are people, what we need really is collaborative clinics, where you can go and see a migraine specialist, a hormone specialist, a skin specialist, a hypermobility specialist, and a mast cell specialist, all in one clinic. But we are where we are.
Well, Katy, I don't agree with you, if I may say so. We don't need multiple specialists, we need a generalist. You know, we need more generalists like Katy and I.
Well, you can just push them all in together.
It's no good saying, go here to see this person, go here to see... We need one person that's got a feel of the whole picture. And I'm going to have another little rant here, if I may, because one of the words that we've been using a lot is complex. And I think I've been very influenced by this thing called complexity theory over much of my career, which I've been involved in. And I've alluded to it earlier, but life's not very straight. Life's not a simple forward, simple input, simple output. It's a complex, shifting network of things that are changing all the time. And if you want to know a little bit more about that, I put a YouTube on. If you just Google complexity and Kernick, it got a little bit out of control. But if you've got a scientific background and you want to know a bit more about complexity, have a look at that. But I think the important practical point is there's no simple right or wrong answer. Certainly these new medications can be really useful, but all these things that we've been talked about, they're all interacting in a complex way. And how do you navigate your way through this complexity? What feels right? Go back to your body, put your hand on your heart and say, what feels right for me?
Yeah.
End of statement. I started with 3 statements, I'm finishing with 1 statement.
I'm just aware that I haven't talked about a link conditions which I'm really very keen for us to think about, and that is the link conditions that people have in childhood. So we're always asking about...
We haven't talked about children.
We haven't talked about children. Didn't
right,
get up there, but it's coming.
I'm going to put it down. Let's do children.
So children have migraine. My youngest patient was 3 when he started getting visual auras and tummy aches, and children present in a slightly different way. They often have a family history, so sometimes parents pick up on it because they've heard that there's a linked condition. But children can get travel sickness, a thing called cyclical vomiting, where they seem to just start vomiting on a regular pattern once a month. They can have babies that have infantile colic are more likely to go on and have migraine attacks when they're older. And children often will have abdominal pain rather than headache. And so if you aren't thinking about children and migraine, and the child keeps having pale skin, feeling very fatigued, wanting to go and have a sleep, maybe feeling queasy or vomiting, and saying they have tummy ache, unfortunately some of these children get over-investigated by gastroenterology paediatricians, have tubes and bloods and all that sort of thing, and eventually somebody goes, hang on a minute, migraine. Or they get older and start developing more typical headache migraines. I had a little boy, this was exactly what had happened. He was 5, he had been having recurrent tummy aches, he had all the different tests that showed up nothing, and he then developed a doctor phobia, not surprisingly, and then he started saying, and my head hurts. And then people went, oh, that's what that is. But it may be that they, I mean, quite often when we're giving talks like this, people come up to me afterwards and go, well, that's why I had tummy aches when I was a child, because nobody's noticed that it's migraine. So I think children, there's a very great need for better awareness in schools, in colleges, in families. If a mother has migraine, I say, you know, and do you have a family history? And she'll may say, oh, my aunt or my mum or my sister. And I'm saying, well, what about your descendants? What about your children? Oh, actually, my 10-year-old's beginning to get tummy aches. So, light bulb moments in clinic quite often. And David's very keen to research more and get better understanding.
Well, it's a huge area of, we published quite a bit of work in this area, and we did a study back in 2009 actually, and 20% of kids in school have headache that impacts upon the quality of their life. This is when migraine starts. The most common age of starting migraine is in your teens. We've repeated the study, and I think probably because of post-COVID, and COVID had a huge impact upon school kids, our attendance figures are absolutely shocking, is that they're now 30%. So 30% of kids have headache that impacts upon their quality of life, about half of which will be migraine, the other will be tension-type headaches. So it's a big problem. But it is massively unmet. It is virgin territory. So whereas in adults, 50% of adults will go and see their GP to seek help, in kids, 10% of kids will go and seek help. So it's a huge unmet need out there, and it seems intuitive that if you get hold of your headache or your migraine at an early age, you get an understanding of it, or get a diagnosis even, you're going to be better off in this long and winding road that I've alluded to earlier. So we're a bit passionate about things like kids, and I'm trying to get a project going off in schools to try and address the problem in schools.
We haven't talked about migraine at work and migraine in school as a disability, and I think if you have a diagnosis of chronic migraine, and we sadly do see some teenagers with that, it is considered to be a disabling condition. And so under the Equality Act, if you're an adult who is working and you have a disabling condition, you are entitled to ask your employer to make reasonable adjustments in your workplace, and that might be reasonable adjustments like turning off the flickering light or giving you a paper presentation instead of making you look at a PowerPoint screen, or it might be adjustments of the sickness policy so that instead of penalising you for repeated shorter absences, they understand that you have a disabling condition that lends itself to you having those attacks, and they don't count them in your in sickness policies. And in schools, there is it behoves the school to understand that they need to make health plan for that child. And again, around March time, I tend to see lots of teenagers who are coming to talk about how they can get school to help them through their exams when they're doing GCSEs or A-levels, because they might need to have a little bit more time. They might need to have access to water so they can take their medication quickly if they get an attack. They might need to not be parked in the sun glaring spot in the exam room. So having some support from your doctor if you are going through that as a teenager can be really, really helpful.
And one of the problems is people actually don't, in occupational settings, they don't come forward because they're going to get they think they're going to be stigmatised. And if I tell my boss I've got migraine, well, that's going to interfere with my promotional prospects. So there's this big problem going back to where we started from again with this person I was talking to down the road in the shop. She'd never been to see anyone. People in occupational settings, and I've given up going into occupational settings and trying to address problems in these contexts because people just don't come forward. And this is one of the problems that we're up against all the time. You know, the stuff is there, but there's huge unmet suffering out there. Katie?
I think we're out of time.
We got 2 minutes to go. That's good timing, actually, although I say so myself. If there are any outstanding questions, we're going to be around. Katie's going to be signing her autographed books, which you can then put on eBay and sell for a fortune. Don't forget, if you want any more information in the future about the workshops on the more holistic approaches, just have a look at that piece of paper on the right-hand side or ask me about it.
And we would love your feedback because...
Feedback, please, tell your friends.
Yes, we want to make sure that we're getting the information out to you in the way that you wanted it, and also to share for our future talks. It always helps. Did I see a hand?
Yeah, I was just going to ask about neck pain, and you mentioned occipital nerve injections earlier, and is that the sort of thing that would help neck pain? Or
well, if you're neck pain migraine, it would. If you've got an intrinsic problem with your neck, which is very rare, particularly because the migraine population is a younger population, it all depends if your neck pain is coming from your migraine or if you have an intrinsic problem with your neck.
It can be helpful, actually, because often around that area, if you have a frequent migraines, it does get quite tense and tight. I think partly because when you have a migraine attack, you tend to be tensing up a little bit because you're trying not to move too quickly. And so it is one of the options to discuss, definitely. And I think also, although we've sort of said, well, migraine gives you the neck pain, I think posture is quite important as well. If you know that you're very head forward, you are going to be putting the weight of your head straining those neck muscles. So looking at some physiotherapy to just make sure that you're optimising your neck health, I think can be helpful. And then physical things like using heat pads or ice can be useful. It changes the blood flow to those muscles and things. Ice blocks pain signals, so it's, again, very individual. I find if I've got a migraine coming on, then an ice pack is really helpful. Other people say, oh, I have to have a lavender wheat bag around the back of my neck and shoulders. I'm like, no, take that away from me. So it's, again, about finding the recipe that works for you, I think. Yeah. We didn't talk much about cluster headache. I love to raise awareness of cluster headache, which is why we have some leaflets here. The main thing to know about cluster headache is it's rarer. It's about 1 in 1,000, but it is a side-locked headache. And people who have cluster headache have the most excruciating pain, and they tend to want to pace around or move. They can't stay still. So if you're wondering, could I have cluster headache, I would direct you to the quiz on the Ouch website. Ouch is a wonderful organisation, the Organisation for the Understanding of Cluster Headache, and you can do their quiz, and it will say at the end of it, you may have X, Y, or Z of the different headache.
I think the simple rule of thumb is, as kids, if you're agitated, you've got cluster headache. If you've got migraine, you're not going to be agitated and banging head against the wall. You want to turn the lights down, turn the telly down. So, yeah. Katie, let's wrap up there. Just signpost people to some further resources. Katie's National Migraine Centre is a fantastic resource. She's podcast. In fact, she's queen of social media and podcasts, so she's got some fantastic podcasts. There's lots of stuff on. We're not quite so well organised, but the Exeter, you can just Google Exeter Headache Clinic. The Migraine Trust is the patient organisation, the patient charity. They've got some really good stuff there as well.
They have a really good helpline if you have queries about work or anything like that.
And you may wish to find a headache specialist. If you can avoid going to see a general neurologist, or if a GP with an interest in headache, try and do some research and the Migraine Trust can be helpful here because they have a list of where the headache clinics are. You're better off being seen in a headache clinic. So I think that's probably about wraps it up. Thanks very much for coming, everyone, and I hope you found that useful. Feedback will be good. You can come again tomorrow. It's always slightly different. We have a slightly different flavour each time we meet. Hopefully that's been useful and given you a little bit more information to help you move forward. And thanks to Bird for our, they also, in the fringe, they always have an applause for the techie. But we'll hang you around for a bit for any questions you might like to ask.
Thank you.
Thank you.
Get to an hour and a half.